Surgical anatomy. The normal thyroid gland weight 20 to 25 grams. The arterial supply is rich and extensive, and anastomosis occur between the main thyroid arteries and the branches of the tracheal and esophageal arteries. There is an extensive lymphatic network within the gland. Although some lymph channels pass directly to the deep cervical lymph nodes, the subcapsular plexus drain principally to the central compartment, juxtathyroid, Golgian, and paratracheal node, and nodes on the superior and inferior thyroid veins. These are level 6, and from there to the deep cervical lymph nodes, level 2, 3, 4, and 5, and mediastinal group of nodes, level 7. The normal parathyroid gland weight up to 50 mg. The color of the parathyroid gland is orange-brown. Most adults have 4 parathyroid glands, 2 superior and 2 inferior. This diagram, or this diagram show the thyroid gland, which is located in the neck, in front of the second, third, fourth tracheal ring. The thyroid gland consists of 2 loops, right and left loop, connected by isthmus, and show the superior thyroid artery, which is a branch of external carotid artery, and inferior thyroid artery, which is a branch of thyrocervical branch, little branch of subclavian artery. And also there is the middle thyroid veins, the superior thyroid veins, and inferior thyroid veins. Physiology. Thyroxine, the hormones triiodothyronine T3 and the thyroxine T4 are bound to the thyroglobulin within the colloid. Synthesis within the thyroglobulin complexes, controlled by the several enzymes in distinct steps. The first step, trapping of inorganic iodide from the blood. Second, oxidation of iodide to iodine. Third, binding of iodine with tyrosine to form iodotyrosine. Coupling of monoiodotyrosine and diiodotyrosine to form T3 and T4. When hormones are required, the complex is resorbed into the cell and thyroglobulin is broken down. T3 and T4 are liberated and enter the blood, where they are bound to the serum proteins like albumin, thyroxine binding globulin, and thyroxine binding prealbumin. The small amount of the hormones that remain free in the serum is biologically active. The metabolic effect of the thyroid hormones are due to unbound free T4 and T3, 0.03 and 0.3% of the total circulating hormones respectively. T3 is the most important physiological hormone and is also produced in the periphery by conversion from T4. T3 is a quick acting within a few hours, whereas the T4 acts more slowly, 4 to 14 days. The parathyroid hormones. The parathyroid gland secretes 84 amino acid peptide parathyroid hormones, which control the level of the serum calcium in the extracellular fluid. The parathyroid hormone is released in response to the low serum calcium or high serum magnesium level. The parathyroid hormone activates osteoclasts to resorb the bone and increase calcium reabsorption from urine, and renal activations of the vitamin D with subsequent increased blood absorption of calcium. Renal excretions of the phosphate is also increased. Calcitonin. The parafollicular cell, C cell, of the thyroid gland are of a neuroendocrine origin and arrive in the thyroid via ultimobranchial body. They produce calcitonin, which is the serum marker for recurrence of medullary thyroid cancer. Pituitary thyroid axis. Synthesis and liberations of the thyroid hormone from the thyroid is controlled by the TSH, thyroid stimulating hormone, from the anterior pituitary. Secretions of the TSH depend upon the level of the circulating thyroid hormone and is modified in the classic negative feedback manner. In hyperthyroidism, when the hormone level in the blood are high, the TSH production is suppressed, whereas in hypothyroidism it is stimulated. Regulation of TSH secretion also results from action of thyrotropin releasing hormone produced in the hypothalamus. Thyroid stimulating antibody. It is a family of IgG immunoglobulin bind with TSH receptor site and activate TSH receptor on the follicular cell membrane. They have more protracted action than TSH, 16 to 24 versus 1.5 to 3 hours, and are responsible for virtually all cases of thyrotoxicosis, not due to autonomous toxic nodules. Serum concentrations are very low, but their measurement is not essential to make the diagnosis. This diagram shows the thyroid function test according to the certain conditions of the thyroid disease. If the patient has euthyroid state, the TSH will be normal, a 3T4 normal, a 3T3 normal. In thyrotoxicosis, a TSH will be undetectable and T3, T4 will be high. In myxedema, which is type of hypothyroidism, the TSH will be high, T3 and T4 will be low. Suppressive T4 therapy, that means patient on thyroxine treatment. The TSH will be undetectable and a 3T4 will be high and a 3T3 will be high and often normal. In T3 toxicity, which is type of thyrotoxicosis, the TSH will be low or undetectable, the 3T4 will be normal, and the 3T3 T3 will be high. Thyroid investigation. Which type of investigation we need to send in patients with the thyroid problem? There is an essential investigation and optional. Essential, serum TSH, T3 and T4 if TSH abnormal. Thyroid autoantibody. Fine needle aspiration cytology of the palpable desecrated swell. Ultrasound guidance may reduce the Thia-1 rate. Optional. Corrected serum calcium, serum calcitonin, and also carcinoembryonic antigen may be used as an alternative screening test for medullary cancer. Imaging, chest X-ray, thoracic inlet X-ray, epitracheal deviation, or retrosternal goiter. Ultrasound, CT scan, MRI for unknown cancer. Some reoperations and some retrosternal goiter. Al-isotope scan if desecrated swelling and toxicity coexist. Thyroid enlargement. The normal thyroid gland is impalpable in most of people, except in very thin patients may be slightly palpable. Goiter is generalized enlargement of the thyroid gland. This is the definition of goiter. Solitary swelling is a desecrated swelling or nodule in one lobe with No palpable abnormality elsewhere during examination. Dominant swelling or dominant nodule is desiccated swelling with evidence of abnormality elsewhere in the gland. Classification of thyroid swelling. We classify the goiter or thyroid swelling to simple goiter, toxic goiter, neoplastic goiter, and inflammatory goiter. Simple goiter, that means euthyroid. We divide it into two types. First, which represent the first stage in the development of simple goiter, diffuse hyperplastic goiter. Example, physiological goiter, pubertal goiter, pregnancy goiter. Second, multinodular goiter, which represent the final stage of simple goiter. Toxic goiter, classified into diffuse toxic goiter, Graves' disease, toxic multinodular goiter or toxic adenoma. Neoplastic goiter, classified into benign and malignant. Inflammatory goiter, classified into autoimmune disease, granulomatous disease, fibrosing, infective, other. Autoimmune called chronic lymphocytic thyroiditis, which is called Hashimoto's disease. Granulomatous thyroiditis called Dequerdian thyroiditis. Fibrosing called Riedl's thyroiditis. Infective. There are many types of infection occur in the thyroid gland, although it is rare, but might occur. Acute bacterial thyroiditis, viral thyroiditis, subacute thyroiditis, chronic thyroiditis like TB, syphilis. Others, amyloid. Simple goiter. Etiology. Stimulation of the thyroid gland by TSH. Inappropriate secretions from microadenoma in the inferior pituitary gland, which is a chronically low level of circulating thyroid hormone. The most important factor in the endemic goiter is dietary deficiency of iodine. Defective hormone synthesis probably account for many sporadic goiter. So, the etiology of the simple goiter, it is either there is a microadenoma in the pituitary gland and it produces inappropriate secretions of the TSH, which is a very rare case, or due to chronically low level of the thyroid hormone. Here we have two causes. The most important cause in the endemic area like our country our iodine deficiency, and the second might be defective in the hormone synthesis due to defect in the certain enzyme. The natural history of simple goiter. Stages in goiter formations are: first, persistent growth stimulation causes diffuse hyperplasia. All lobules are composed of active follicles and iodine uptake is uniform. This is diffuse hyperplastic goiter, which may persist for a long time but is reversible if stimulation stops. Later, as the result of fluctuating in stimulation, mixed patterns develop within the area of active lobules and area of inactive lobules. The active lobules become more vascular and hyperplastic until hemorrhage occurs, causing central necrosis and leaving only surrounding ring of the active follicle. Necrotic lobules coalesce to form nodules filled either with iodine-free colloid or mass of a new but inactive follicle. The fifth stage, continual repetition of this process, results in nodular goiter. Most nodules are inactive and the active follicles are present only in the internodular tissue. Diagnosis: the patient is euthyroid, so the patient has no clinical features of hyper or hypothyroidism. The nodules are palpable and often visible. They are smooth, usually firm, not hard. Goiter is painless and move freely on swallowing. Hardness and irregularity due to calcification may simulate carcinoma. A painful nodule, sudden appearance, or rapid enlargement of the nodule raise the suspicion of carcinoma, but is usually due to hemorrhage into the simple nodule. Differential diagnosis from autoimmune thyroiditis may be difficult, and the two conditions frequently coexist. Investigations. Thyroid function should be assessed to exclude mild hyperthyroidism. Thyroid antibodies tested to differentiate it from autoimmune thyroiditis. Ultrasound is a gold standard assessment. Fine needle aspiration cytology is only required for the nodules within the goiter that demonstrate ultrasonic features of concern. The biopsy should be performed under ultrasonic guidance to ensure the correct nodule is sampled. CT scan of thoracic inlet is the best modality to assess the tracheal or esophageal compression. Complications. First, tracheal obstruction may be due to gross lateral displacement or compression in lateral or anterior posterior plane by retrosternal extensions of goiter. Second, secondary thyrotoxicosis. A transient episode of mild hyperthyroidism are common, occurring in up to 30% of patients. Carcinoma, an increased incidence of cancer, usually follicular, has been reported from endemic areas. Prevention and the treatment of simple goiter. In endemic areas, the incidence of goiter has been significantly reduced by introductions of iodized salt. In the earlier stages, hyperplastic goiter may regress if thyroxine is given in the dose of 0.15 to 0.2 mg daily for a few months. Although the nodular stage of the simple goiter is irreversible, more than half of the benign nodules will regress in size over 10 years. Most patients with multinodular goiter are asymptomatic and don't require operation. So, the surgery is indicated for a multinodular goiter in the following points. First, features of underlying malignancy by examination, by ultrasound, or FNA. Second, swallowing symptoms. Third, cosmetic reasons. Fourth, tracheal. There is choice of surgical treatment in multinodular goiter. That means type of surgery. First, total thyroidectomy. Second, subtotal thyroidectomy. Total thyroidectomy advantage immediate and lifelong replacement of thyroid, while in subtotal thyroidectomy, partial resection of each, removing the bulk of the gland, leaving up to 8 grams of relatively normal tissue in each remaining. This gentleman had a multinodular goiter, big multinodular goiter. The second subject is the clinically discrete swelling. Common condition, palpable in 3 to 4% of the adult population, otherwise is detected by ultrasound. 3 to 4 times more frequent in women than men. Diagnosis. About 70% of discrete thyroid swelling are clinically isolated, and about 30% are dominant. So the most common discrete, and this common is dominant. Importance of discrete swelling lies in the risk of neoplasia compared with other thyroid swelling. 15% of isolated swellings proved to be malignant, and additional 30 to 40% are follicular adenoma. The remaining are non-neoplastic, for example, largely consisting of area of colloid degeneration, or thyroiditis, or cyst. Investigation. Thyroid function, T3, T4, and TSH. If hyperthyroidism, put in your mind toxic adenoma or toxic multinodular goiter. Combination of toxicity and nodularity is indication for isotope scanning to localize the area or areas of hyperfunction. Autoantibody titer to diagnose chronic lymphocytic thyroiditis. Isotope scan, except when toxicity associated with nodularity. Ultrasound. Ultrasonic features in thyroid swelling associated with thyroid neoplasia. What are the ultrasonic features that give you clue for risk of malignancy, including microcalcification, increased vascularity, but only macroscopic capsular break and nodular involvement are diagnostic of malignancy and are these proved by histopathology. Fine needle aspiration cytology, FNA. Fine needle aspiration cytology should be used ideally under ultrasound guidance. FNA is reliable in identifying papillary thyroid cancer, but cannot distinguish between benign follicular adenoma and follicular carcinoma, as this distinction is dependent not on cytology but on histological criteria, which include capsular and vascular invasion. Fine needle aspiration cytology is both highly specific and sensitive. Radiology. Plain film have previously been used to assess tracheal compression and deviation. CT scan is also useful if ultrasound has identified metastatic disease in the neck, as it can assist surgical planning and also assist the superior mediastinum and lungs. Laryngoscopy. The flexible laryngoscopy has rendered indirect laryngoscopy obsolete and is widely used preoperatively to determine the mobility of the vocal cord. Presence of a unilateral cord palsy coexisting with an ipsilateral thyroid nodule of concern is usually diagnostic of malignant disease. Core biopsy, rarely indicated in the thyroid disease, useful in the rapid diagnosis of widely invasive malignant disease, for example, anaplastic carcinoma, or in the diagnosis of lymphoedema. The main indication for operation is the risk of neoplasia in a clinical discrete nodule, which include follicular adenoma as well as malignant swelling. 50% of isolated swelling and 25% of the dominant swelling should be removed on the grounds of neoplasia. The age, sex of the patient, and size of the swelling may be relatively indications for surgery. A clinical criteria to assist in selection for operation according to the risk of neoplasia and malignancy include hard nodule, irregular nodule, recurrent laryngeal nerve palsy, deep cervical lymphadenopathy. The incidence of thyroid carcinoma in women is about 3 times that in men, but the secretive swelling in male is much more likely to be malignant than in female. The risk of carcinoma is increased at either end of age range, and the secretive swelling in teenagers of either sex must be professionally diagnosed as carcinoma. The risk increases as age advances beyond 50 years, more so in males.